Infection, gas gangrene. Etiology, anaerobic spore-bearing bacilli, Clostridium. Saccharolytic group and proteolytic group. The saccharolytic group consists of Clostridium golgi, Clostridium septicum, and Clostridium edematans. The proteolytic group consists of the Clostridium sporogenus, Clostridium histolytica, and Clostridium tertium. The Clostridia produce toxins locally. The saccharolytic Clostridia microscopic picture, proteolytic Clostridia microscopic picture. Clostridial toxins. The alpha toxin is a necrotizing lithosinase, which is an important one. Other toxins include collagenase, protease, hyaluronidase, lipase, and hemolysin. Predisposing factors. Lacerated wounds in bulky muscles like the gluteal region and the thigh. Foreign bodies and or devitalized tissues. Muscular ischemia after ligation, after vascular injury, tight bandages, tight plaster casts, and sutures under tension. Infection with aerobic bacteria consuming oxygen, making an anaerobic medium. Spoiling of the distal wounds by stools in patients with fecal incontinence. Pathology. It is an acute spreading gangrene with gas formation and profound toxemia. Clostridial toxins diffuse locally, destroying the microcirculation, allowing further rapid extension. The saccharolytic organisms cause necrosis of the muscles fibers, thrombosis of the blood vessels, blood hemolysis, fermentation of glycogen of the dead muscles, and liberation of carbon dioxide and hydrogen. The liberated blood pigments give brick red color of the dead muscles. The proteolytic organisms ferment proteins of the dead muscles, liberating ammonia. The liberated ammonia neutralizes the acid products of the saccharolytic organisms. Hydrogen sulfide combines with iron salts of hemoglobin, forming iron sulfide, which gives the greenish-black discoloration to the tissues. Serious systemic manifestations and effects, pallor and jaundice due to hemolysis, degenerative changes in the liver, kidney, and suprarenal glands. Incubation period, few hours to few days. General clinical picture. The patient looks pale, anxious, and apprehensive, may be raised temperature, marked tachycardia, and cold, clammy hands. May be icterus, oliguria, or shock in severe cases. Local clinical picture, local pain and numbness, swollen wound with gas crepitus, sanguineous wound discharged with characteristic odor, brick red, then greenish, and finally black discoloration of the affected muscles. No muscular contraction and no bleeding on cutting of the affected muscles. Greenish or black discoloration of the underlying skin. Possibility of the presence of multiple blebs full of foul-smelling dark fluid. Differential diagnosis from other clostridial infections and from non-clostridial infections. Differential diagnosis from other clostridial infections. Simple contamination. Open superficial contaminated wounds with Clostridium but without infection. Brown seropurulent discharge. The healthy surrounding tissues limit the infection. The debridement of the superficial wound is enough for treatment. May turn invasive on further injury or hemodynamic instability. Gas abscess, Welch abscess. Localized non-invasive infection without muscular involvement. The incubation period is 1 week or more. Little pain, moderate edema, and no toxicity. Brown seropurulent exudate with autopsy odor may be gas in the affected area, treated by incision, drainage, and penicillin. Anaerobic clostridial cellulitis is an invasive subcutaneous infection without muscular involvement, predisposed by ischemic injury of the subcutaneous tissue may follow appendectomy. Edema, skin discoloration, and gas crepitus. Very mild systemic manifestations due to non-affection of the muscles. Localized clostridial myositis is a rare non-invasive infection with muscle involvement and good vascular perfusion. Edema plus crepitus plus odor may be fever and tachycardia. No severe signs of toxemia. Edematous gangrene, infection by Clostridium edematans, marked muscle edema but without gas production. Highly aggressive and fatal, acquiring aggressive treatment. Differential diagnosis from other non-clostridial infections. Gas-producing infections like gram-negative bacilli plus gram-positive cocci. Non-virulent infection responds well to incision and drainage. Strangely, Clostridium edematans doesn't produce gas, and Escherichia coli produces gas in the affected tissues. Surgical emphysema, no signs of toxemia, no peripheral circulatory failure. The wounds are healthy looking. Diagnosis. The clinical picture, the presence of large gram-positive rods from the stained smears of the exudate and or the affected tissue. Prevention. All of the clostridial infections are prevented by adequate wound debridement with leaving the wound open, administrations of suitable antibiotics, penicillin, adequate circulatory support. Treatment. Wound management. Debridement. Decompression of tight fascial compartments. No wound closure, amputation of a useless limb, and colostomy to divert stools away from the wound sites. Hyperbaric oxygenation. Oxygen supply at 3 atmosphere for 1 to 2 hours every 6 to 12 hours. This inhibits both of the bacterial invasion and the production of the alpha toxin. Fresh blood transfusion is helpful to carry the oxygen. Antibiotics, penicillin 20 to 40 million units per day. Clindamycin or metronidazole in allergic patients to penicillin. Multiple antibiotics are administered in cases of mixed infections. Anti-gas gangrene serum is historical and is not used in the modern surgical practice. Prognosis. The mortality rate is 20% and is increased with delay of the start of the treatment, associated severe injuries, invasion of vital structures, and pre-existing illness. Salvage for the affected limb. Life-saving amputation is better than leaving a useless limb. Good luck and best wishes.